Okay, I think we're all here. And as we continue to join, I'm going to go ahead and kick us off for today's meeting. Thank you everyone for being here. It's another great day at the California Telehealth Resource Center. We are really excited to bring the second in our AI learning series to you today. It's going to be a great session. Today's focus is going to be healthcare AI, rapidly evolving regulatory and payment environment. What every clinician should know. Very exciting stuff. So a few reminders for everyone as you're joining us. You have been muted, your camera is off, but we do want to hear from you. So please use the chat, use the Q&A function. We want to hear your questions. If you have comments for our presenters, use them in the chat. We'll collect all this and hopefully there will be some time for Q&A from our presenters. And if you have any other questions, we'd love to take them after the session or offline, but we do want to hear from you. So we hope to see a lot of participation in the chat and Q&A. Also, please note that the session is being recorded. So if you have to hop off early or you really like what you hear today and want to share it with a colleague, you will have an opportunity to share it and view it on YouTube later this week. One last disclaimer for you, though we do have some great subject matter experts joining us today, please know that CTRC is only here for informational purposes and we do not offer legal advice. Any products or services that are mentioned in today's presentation, we have no relevant financial interest or affiliation. The California Telehealth Resource Center is wonderfully supported by the Office for the Advancement of Telehealth. From HRSA, CTRC also appreciates the support from the California Department of Healthcare Access and Information's State Office of Rural Health. And with that, I will transition over to today's moderator for our session, CTRC's very own Sylvia Trujillo.
Thank you, Aislinn. And again, we just want to encourage you all to submit your questions and we want to hear from you. So I'm really excited today to have you here. Two incredible experts in the healthcare AI space. These are two trailblazers who really have a depth of knowledge. First, I want to call out Sybil Rohrenbeck. Amongst many accomplishments and roles, she's the executive director of the AI Healthcare Coalition, the chair of the ABA Health Law and Policy Committee, an adjunct associate professor at American University, and really an expert on payment and regulatory issues as they apply in the healthcare AI space and digital modalities more broadly as well. Similarly, David Vidal is joining us. He's the vice chair of the Software as a Medical Device Regulation in the Mayo Clinic Center for Digital Health. He's part of the Leadership Council for the Health AI Partnership, a multi-stakeholder collaborative with the mission to empower healthcare organizations to use AI safely, effectively, and equitably. Sounds like we have the right duo here for what we're interested in. And David, really notably, as well as Sybil, have been really active and involved in some of the groundbreaking innovators in healthcare AI applications, having worked on getting de novo authorization, David, for the first autonomous AI system. David helped shepherd that process. And Sybil, for the same entity and organization, was really instrumental in shepherding through the process of payment and quality measures in the same space. So with that, we're going to move to the next slide. I want to just lay out a couple of really foundational issues for you as clinicians and other stakeholders around what really drives digital adoption in an innovation space. Clinicians in their checklist should always be asking, is it effective? What is the evidence base? Is it safe? What is the regulatory regime? Can I get paid for the modality, the services, and the technology? What are the compliance requirements and liability risks associated with the adoption, whether it's related to HIPAA and interoperability or payment issues and or medical liability? Second to last is really, what is the infrastructure? Is there broadband connectivity? In particular, are there devices? And then last, will it really work in my practice? Can it be integrated into the workflow, the EHR? And do I have the right staffing? And I can't take credit for these questions. They were derived from a set of questions of clinicians conducted by the AMA back in 2016 and repeated back in 2019 and 2022 around digital adoption. So today, Sybil and David will be really talking about the top 4 questions. Is it effective? Is it safe? Will it be covered? And what are the compliance requirements and liability risks? We will be having additional webinars to address the latter 2 questions. So with that, I'd like to move to our sort of framework for how we're thinking about these issues. Really, it can be distilled into these 4 legs of the stool. Is it safe? Is it effective? Is it sustainable? Is it scalable? And is equity really embedded through all of those things? So lastly, just really quickly between David and Sybil, next slide, we're going to have David provide a deep dive into the regulatory question around does it work and is it safe? And what does that overview look like? And then Sybil is going to sort of broadly look at the environment around coverage and payment and other regulatory and safety regimes in place. So with that, I'm going to hand it over to David.
Excellent. Thank you, Sylvia. And I will take over the screen, if that's okay.
Sounds good.
There we go. You can all see?
Yes.
Great. Yes, thank you for the introduction, and really a pleasure to be here today. And I hope you leave, so I'll take the first half of the presentation portion of this, and I hope you leave feeling empowered a little bit here. Really trying to go a flyover of some of the regulations with the intent of helping those that are on this call and anybody who watches after understanding what are the obligations of folks that are building and deploying AI within healthcare right now. I don't have any specific disclosures related to this content, and as was already mentioned, this is not legal advice. And again, I think the objective here today is to just give you, empower you with the ability to understand what are the regulatory obligations for the folks that are building and manufacturing artificial intelligence that's impacting patient care. And so if you are either deciding whether you want to use AI or whether you're subject to AI as a patient, you should know what should you expect from these manufacturers? What can you ask or what can you demand? So that's hopefully what you walk away with here in my portion. And I'm going to start with just one definition, just to level set here a little bit, partly because it's in my title and partly just to set kind of a threshold issue that I'm going to spend about the first half of my presentation on, which is this term software as a medical device. So software as a medical device meets the definition, FDA's definition of medical device, which is it is intended, it's a software function intended for the use in the diagnosis of a disease or condition or in the cure, mitigation, treatment, or prevention of a disease. That's very, very broad, and FDA does that by design. So it meets the definition of a medical device, but software as a medical device is also unique in that it's a standalone function. So this software all over healthcare right now, a lot of that software just helps equipment function the way it's supposed to equipment, or helps with scheduling or helps with certain things. This software as a medical device is a standalone function to perform that medical function. And examples that we give just to level set would be something like taking an image of a mole and using AI to determine whether that mole in the image has melanoma, or an AI that looks at an EKG and predicts or detects signs of disease. That's what software as a medical device is. So I'm going to focus a lot of my time on that. AI or software that meets the definition of a medical device and is a standalone function that performs that medical function. And the reason that definition is important for the content that we're talking about today is what can you expect from the AI that's coming to clinical practice or that's already in clinical practice that you as a patient might be subject to. The amount of rigor that FDA would expect for that AI depends on whether it's regulated or not. It depends on whether it meets that definition of a medical device or qualifies as software as a medical device. And so this is a little diagram of the risk, and FDA is always risk-based of the different categories of software or AI or really any technology that the FDA would review. And if we look at the green, that would not be regulated by the FDA. So if you're looking at a software solution or a vendor that's coming into clinic that meets one of these categories, which I'll get into in a moment, you would not be subject to the FDA rigor. However, if you start getting into the yellow or the red, you would be subject to a heavy degree of FDA rigor, which I'll describe in a moment, which also means you can expect quite a bit more out of those AI or software manufacturers. So this is our rubric. This is and there's other resources that I'm happy to share after the fact. This is how we decide whether a software function is regulated by the FDA. We spend actually a lot of our time, our team at Mayo Clinic, doing just this analysis, helping our innovators understand, is their software technology subject to the FDA controls or is it not? And so I'm just going to walk through this, and hopefully it's a rubric that you could reuse if you're looking at different solutions. So the first question we have is it a medical device? Is that software intended for use in the diagnosis, cure, mitigation, treatment, or prevention of a disease or condition? If it's just for educational purposes or just for scheduling or billing, the answer would be no, and it would likely not be a regulated medical device. However, as I described, it's a pretty broad definition. If the answer is yes, which a lot of things are, the next thing we would look at is, does that software function or that AI meet any of the exempt categories that the FDA has provided us? And that comes from the 21st Century Cures Act. And a highlight of those categories that are exempt include administrative support functions. Again, even if it meets this definition, if it really is intended for more like billing and workflow, that would be more in the administrative support. It would be exempt from the regulations. The electronic health record itself is not regulated by the FDA. I think Sybil's going to mention a couple areas where it does have regulation, but it's not regulated by the FDA. General health and wellness is generally not regulated by the FDA. If these are the things on our Apple Watches or our smartphones that are helping us track diet and sleep and so forth. And then we have a category of really the pipelines, the data transfer systems that again would not be regulated. Again, if it meets one of the exempt categories, it's not regulated. So if you have a vendor or an AI solution that kind of feels more like this, and they're saying they're not regulated, then that would be a reasonable position to take. If the answer is no, then we look to our last exemption, which also is under the 21st Century Cures Act. I'm going to spend a little more time on this in subsequent slides. We ask, well, is this exempt clinical decision support? So does this AI or this software function meet the 4 criteria that would be necessary in order to be non-device clinical decision support? I'm spending a few more slides on this because it's a really confusing category, because we have 2 categories of clinical decision support. We have non-device clinical decision support, which would not be regulated by the FDA. And then we have our medical device clinical decision support. It's often difficult to determine between the 2. And I want to, again, leave you with a little bit of an analysis to be able to determine between the 2. Really, it's about the requirement to meet all 4 of these criteria in order to be non-regulated. And those criteria are: the AI or the software function cannot process images, signals, or patterns. That's why if you look at radiology or cardiology or digital pathology, they're leading in the submissions and approvals and clearances from the FDA, primarily because they don't meet this criteria. So they are, in more cases than not, subject to the FDA controls. Criteria 2 is it's involving medical information, which I'll get into more in a moment. Criteria 3 is that it must be supporting a healthcare professional, not the healthcare professional cannot be reliant on the output. And then criteria 4 is about no reliance, but it's more about the transparency aspect, which I'll go into in a moment. If it doesn't meet the 4 criteria, it would not be, it would likely be a medical device and regulated. So just as I go into the next one to really talk more about clinical decision support, again, this is a different view of the scope of different AI and software functions under this category of digital health technologies. Over here, we have those things that do meet the definition of a medical device, and those would fall in either class 1, class 2, or class 3, and those would all be based on risk. And over on the non-medical device functions and categories, again, these are categories that FDA has determined are lower risk and therefore don't need the same level of rigor or oversight. And this is a reflection of the different categories. But looking here specifically at clinical decision support, here's the 4 criteria broken out in the actual language of the Act. Again, not intended to acquire or process or analyze images, signals, or patterns, radiology, cardiology, digital pathology. Here, it's intended to be about medical information. And this is a little bit of a confusing category because medical information in the eyes of how this is interpreted is really intended to be more like what you would find in an electronic health record. Or the example that FDA uses is what a physician and physician interaction might look like in a hallway, really be able to communicate basic information about a patient. What this is not intended to be is those multi-million data points that you find that one nuanced insight buried very deep in there. That would likely not be medical information, probably be something more than that. Criteria 3 is where we spend a lot of our time. It must be supporting or providing recommendations, not relied upon in clinical practice. And there's 2 categories of this that are really informative of whether you meet this criteria. One is, does that AI or software tool provide a singular output? For example, if it says, it still might be a risk score, but if it says, oh, there's a 92% chance that this is cancer, that's hard to not rely on. That would be in FDA's eyes less supporting or providing a recommendation and more driving care, because the physician would see that result and be like, oh, I need to take action. Another circumstance that would not meet this criteria is something that's very time critical. So the example that FDA has provided is like in a sepsis situation, where if we have an AI that's trying to determine whether sepsis is at high risk for a certain patient, that's time critical. And it's less likely to meet this criteria because you don't have as much time to analyze and reflect on that result. You want to take immediate action. So it's less supportive and more driving. So we spend a lot of time in the nuance and in the weeds of determining whether we meet this criteria when we're talking about this category of non-device or medical device clinical decision support. And then finally, we have our 4th criteria, which is intended to say, in order to be non-medical device, we need to provide information about how that result was produced in order for the physician to make their independent analysis and independent judgment. Again, you can meet all these criteria, and if you don't ever show the physician how you came to that conclusion, they're likely to rely on it. So this category really is what I like to call the transparency category. It's really being transparent about what underlies the calculation so the physicians can use that. And I'll touch back on this in a moment when I talk about liability and accountability. Okay, so I spent a lot of time really trying to determine what is non-medical device. But what if you are a medical device? What should you, or what can you as a physician or as a patient expect of companies that are subject to FDA regulation? And we've created what, even though it's still complex, is we try to simplify it in the best way we could. This is the process that everybody who's subject to the FDA would go through. We have our design planning, where we gather requirements and understand user needs, our inputs, our outputs, where we've started our testing, our verification, validation, transfer, and deployment. There's specific policies, procedures, regulations, forms, documentation that would be created as evidence of following all of these steps that I could spend a whole nother talk on, but I don't have time for that. It's all at its core governed by a quality management system, and it's got management and accountability and responsibility all around the edges. Going into more details of this, if they're regulated, you can expect them to have answers, or they should have answers to all of these steps that are detailed out in the regulations. But what if it's not? What can we expect if it is not subject to FDA regulation, which a lot of companies are not subject to FDA regulation? And this is a really evolving place. There hasn't been a whole lot of specific accountability for the non-regulated space yet, but we see a large shift and a large evolution. 2 examples are the White House blueprint for AI and the White House executive order on AI. They're starting at the federal level to use terms that we're used to in the regulated space, like establishing accountability and performance, transparency, accountability, safety, ethics. These are all starting to be built in there. So we can start to use these to start asking the questions. Well, how are you going to comply with this? How are you going to present evidence once these things become more of a formal requirement? Another expectation that we can have of the non-regulated space is making sure that they substantiate their claims. And the Federal Trade Commission has been a really active player in this space, and have actually taken action against certain companies that are building AI, that have built products and are implying that that product is more diagnostic in nature without evidence to back that up. And Federal Trade Commission has actually taken action against those companies. So if you are in a non-regulated space and you're asking or trying to understand better what that AI or software technology is supposed to be doing, look at their claims and then ask for evidence. That's a very fair request. Okay, in my last minute or two before handing it over to Sybil, I want to just make one point, and it's really kind of illustrated through an example, and that is the evolution of liability and accountability for the use of AI in practice. And I really, and this is some of my own thinking, but I really like to think about this as distributed liability or distributed accountability, not trying to place all liability and accountability on one particular player in the execution of an AI solution within healthcare. And this has come out in a couple of frameworks, which I love. What part, we have to ask ourselves, what party is best positioned to take accountability for that particular risk that you're looking at? And so in a simplified version, we have our developers or manufacturers of solutions. We have our healthcare organizations that are purchasing and distributing those tools. And we have our physicians that are using those tools. And in many cases, like with clinical decision support, using it to augment decision-making, but they still make the final decision. And I want to highlight three things that are either proposed rules or guidance documents, and Sybil's going to go into more detail for us. But really talk about those three players again from a policy perspective, from a federal policy perspective. And one is the perspective of what is imposed upon manufacturers. What are we expecting of our manufacturers for those clinical decision support solutions? That comes from the FDA. Another proposed rule that I'll show in my next slide has to do with the Office of the National Coordinator, which is really more about healthcare IT certification. I like to think about that as what do we expect of those entities that are delivering the tools, like the electronic health record. And then we have the Office of Civil Rights that has a proposed rule from, related to physicians or covered entities. And here's those rules. And I'm going to go right back to my criteria for clinical decision support, if you remember what that was for transparency. Who's responsible for transparency? How do we ensure that transparency is occurring for effective use of AI in clinic? The FDA says if you're the manufacturer, if you want to be a non-device, criteria 4, you have to be able to provide the information for the physician to be able to make the final decision. If you don't meet that criteria, you're regulated, and then just by nature of being regulated, you're going to provide that information. So really, there is an expectation of transparency from the FDA towards the manufacturers. The ONC has a proposed rule where they basically, in short, and so we'll go into more detail, have an expectation that the information that's provided is actually delivered to the user. So we can't just have the manufacturer build it and then it stops there. It needs to be provided. And then I want to spend just a little bit more of a moment on this last proposed rule from the Office of Civil Rights, which proposed that physicians, users, trained experts would potentially have liability for the use of AI if they rely on the AI result, even if they don't design the algorithm or have knowledge of how it works. And think about this proposed rule in isolation. If this proposed rule says all physicians have liability for use of the AI if they rely on the AI, even if they have no idea how it works, we're going to have an issue with innovation. We're going to have an issue with liability, and we're going to have a lot of fear over the use of these tools. And that's a state that I hope we don't get to, a fear-based way to use and deploy AI. What we need is the coordination, right? If we have a manufacturer that is fully responsible and liable for producing the information, we have ONC, which is fully responsible for delivering the information, then we have physicians who are using this in a very informed way. Maybe it does make sense to have that shared liability, but each party needs to play its own role. So I really want to make that point, but also highlight this for you that this is evolving, and know that these types of rules are coming out, and you're going to want to be aware and ask the right questions of it if you're looking to use or be subject to AI solutions. And with that, I think I'm right about at my time, so I'm going to pass it over to Sybil and unshare my screen here.
Thanks, Aislinn. And I see that I don't think I can share my video. So if you want to pull my video up, that would be great. Thank you so much, David. Really excited to continue on the discussion today and kind of pick up right where David left off. I'm Sybil Wernbeck. I serve as Executive Director of the AI Healthcare Coalition, and most of our members are innovators who have the first type of AI that David was discussing, FDA authorized and regulated AI. So we've been working a lot on advocacy in that space and trying to inform policymakers about some of the things that we, some of the innovations that we have and our members have, as well as how they can be deployed in a clinical setting. Hopefully you all can see me now. So picking up where David left off, and I want to give a shout out also to my colleague from our Hogan Lovells privacy team who's on the line, Alyssa Golay, who helped prepare a lot of the information we have here on these first couple slides. But the HHS Office of the National Coordinator did put out finalize this rule around health data technology and interoperability, where they included really significant new rules around algorithmic transparency. The AI Healthcare Coalition had commented that we would love to see FDA tools, which do have to undergo a rigorous review after they've gone through the analysis that David described, treated differently in this rule, but ONC did come up with sort of one set of rules around how folks need to provide information related to EHR offered products. Specifically, there's new reporting that will be required around functionality, configuration, and other information related to what the agency is calling decision support interventions. And these are for health information technology or electronic health records, which receive a certification from HHS, which the majority of hospitals and medical providers, clinics participate in with certified electronic health records systems. So that's, your Epic, Cerner, very large systems typically do have this certification. Interestingly, in the rule, the ONC did make a really important clarification, which is that the HIT developers or the electronic health record vendors are responsible only for those predictive DSIs or AI sort of tools or modules that they are supplying as part of their certified HIT. And I'll talk a little bit more about that in a second. But among other requirements, they will need to have sort of ongoing maintenance and have information around risk management practices, risk analysis and governance, sort of the meaty information related to every type of AI tool that they're using within the EHR that's being offered as part of their portfolio of services. They will need to include a lot of this information for clinicians. Next slide. So what is the scope of this rule, and do we have to report? And thank you, Alyssa, for helping me on this piece of it. There was a lot of questions around, what was changed in this rule, and ONC did come up with some nuanced language here, but essentially they said that if the AI is being supplied by the EHR vendor, then the information will be required to be reported. And that was a narrowed focus from what was in the proposed rule. They specifically talked about how supplied by would include, when an entity has a contract specifically covering the enablement and use of such technologies. So for example, if you have one of the tools that David described, like a cardiac tool that is an AI that's working sort of as a medical device, but the information is being fed into the EHR. If it's not something that's part of the suite of services that the EHR has, we are interpreting this generally as to not require that reporting. I am aware that we may get more information and guidance from ONC, but that seems to be their intent in this rule thus far. Next slide. So one question we've gotten a lot too is, I have an FDA authorized system. Does that mean that I'm exempt from this new ONC rule? And the answer to that is no. In fact, there were many stakeholders who asked ONC to exclude them from these new reporting requirements. And ONC expressly declined to do so. There was a question of whether, if you've already gone through the FDA process, it would be duplicative to require significant reporting to HIT vendors for those products that have been already given sort of their blessing by FDA to be out there and safe for the public and safe for clinicians to use with their patients. Unfortunately, ONC decided in their response that they would decline to include any exclusionary criteria. And therefore, whether or not you have an FDA authorized system, that's not really the question to be examined when thinking about whether the information needs to be reported on the EHR that the hospital, FQHC, physician clinic is utilizing. Next slide, please. So how can we learn more about these new requirements? ONC has an informational session actually coming up tomorrow at 1 p.m. Eastern. We have the link here. It's also on the ONC website. I think they'll go through more sort of practical applications of this rule. And I know that they're getting already a ton of questions about what needs to be reported and what falls within the scope of a predictive DSI AI module that would need to be reported. So that may be a good place to listen in if you're interested on this piece. Similarly, we do already know some key dates. So by December 31st, 2024, HIT developers that are, certified HITs will need to be meeting these requirements, and they will also need to have provided the updated version of their software, of their system to their customers by the end of this year. Starting the very next day, January 1, 2025, developers will have some of these obligations put on them specifically. And so really we're looking at this going into effect at the end of this year, beginning of next year. And you may see a lot of information coming across from your electronic health record vendor related to this. And similarly, some information from any of the AI vendors that you use or AI tools that you have incorporated into your practice. Next slide. So those are a lot of the transparency requirements. The other question that we get a lot is, how can these systems be paid for? For those FDA authorized AI models who have received or in the process of receiving some sort of medical code to bill, there are a number of different ways that Medicare, we're going to focus on Medicare and not talk about commercial payers for purposes of time, but that Medicare is reimbursing for these services. And that's been happening really for many 3 or 4 years now, I would say, but that's several rule cycles that we've seen CMS sort of embrace and allow payment for some of these AI services as medical services. And like David noted, many of these are imaging type services. So we're seeing services in the space of cardiology and the space of ophthalmology and others where neurology, where there's an imaging component, there's been an FDA authorization. The product has either gotten an FDA approval or is in the process of, receiving that approval or just received it. And we now are having, payments through these multiple different pathways. Of course, we're still working within the same Medicare system that we've had for many, many years. The other day, someone was talking to me about HCFA, if people remember that. So we are still working within the same statutes and regulations that we have for medical services generally, which means that they are still all based on, if we can go to the next slide, that would be great. They're still based on these site of service. So we have one system for inpatient hospital services. We have another system for outpatient hospital services. And then we have a third for physician office or clinic services. And the payments are different, even if it's for the same product. Within the inpatient hospital services, we do have a pathway which was not created for AI at all. But we've now seen a number of AI models receive reimbursement as medical services under this pathway, which is the NTAP, or the new technology add-on payment. Viz AI has Viz LVO was an early one that received payment under this pathway. And I'll talk more about this pathway in a second, but you can receive reimbursement through that pathway or as part of a diagnosis related group, or DRG, as we typically would see for inpatient hospital services. On the outpatient hospital service side, there is a similar but somewhat different pathway called the new technology ambulatory payment classification. It's often just termed new tech APC pathway. That has its own set of criteria that I will walk you through. But we also are seeing some services just sort of skip the new tech APC pathway and just receive payment through a clinical APC as any other medical service would, which has been super interesting. Physician office and clinic, we have the Medicare physician fee schedule. These medical device services, which provide diagnostic information or diagnosis, fully autonomous AI diagnosis in some examples, do receive fee-for-service payment under the MPFS. But for each of these, and for many of the regulations we have on the books, they're sort of being fit into a pre-existing system. And so we're still going through bumps in the road in terms of, will these payment pathways be sustainable for the number of AI services that we anticipate and expect to come online even over the next 5 years? But in terms of understanding what we do have today, it's important to know that we do have payment running today for many different AI medical services in each of these 3 buckets. If we can go to the next slide. So inpatient setting, if you would like an NTAP, and this is, I'm saying the developers are applying for these things, and there's a whole system that's set up with different deadlines than the annual fee schedules, even a whole system that's set up within CMS for a developer of an AI medical device to apply for example, an NTAP payment. And it goes through a process of review by CMS, which is quite lengthy. But the concept is that once you've gone through that review and they don't accept a lot of the applications, that a product could receive an NTAP payment, which is time limited, and that then providers, when utilizing the service for their patients, could bill that code for reimbursement. So to be eligible for an NTAP payment, generally, the medical service or technology must be new, and there's specific newness criteria and analysis that you run through. The medical service or technology must be costly, such that the rate otherwise applicable to discharges, including the medical service or technology, is determined to be inadequate. In other words, in layman's terms, it has to be, the cost for the medical technology has to be such that the DRG for that episode of care or for that service wouldn't otherwise cover it. And the developer really has to make that case utilizing existing commercial data to the agency to receive the NTAP payment. And then lastly, the service or technology must demonstrate a substantial clinical improvement over existing services or technologies. And there's a whole analysis with respect to what constitutes a substantial clinical improvement. But in general, CMS is looking here for, do you really need a payment outside of the DRG in the inpatient setting for this new technology? And for some, they have determined that yes, it is important to have that additional payment, because the existing payment for that service, for the DRG and that sort of suite of services, is not sufficient to cover this technology. It's going to be really impactful and important for patients. And this is a new thing that we want to try to see if it does lead to better clinical care. So this is one option. And if you are seeing patients in an inpatient setting, it may be that some of the AI tools that you are utilizing would qualify for a payment under the NTAP pathway. Next slide. It was interesting that at the end of 2021 or the beginning of 2021, CMS also gave an additional kind of break to some folks who were seeking payment and reimbursement in the inpatient setting, namely that those medical devices that are designated under the FDA's Breakthrough Devices Program, which is sort of a special program that the FDA has for particularly innovative devices, that they could qualify for NTAP under an alternative pathway. What that did was just sort of tweak some of those underlying elements that I talked about in terms of the analysis. And, just the fact that you have received breakthrough device authorization, agree should mean something with the CMS and receiving some reimbursement. Some interesting things around NTAP, it is time limited. There's interesting information around, like, you have to be new, meet this kind of newness criteria period. So, to meet this FDA breakthrough sort of exception or alternate pathway, it does need to be within 2 or 3 years that it has come out. So a lot of this for the on the developer side has really been synchronizing these multiple different criteria, programs, pathways, and trying to synchronize those things so that you don't kind of left out of a payment that otherwise your clinicians could receive for the use of the technology. Next slide, please. Outpatient setting. For now, we do have an outpatient payment system in Medicare, and in the outpatient setting, CMS has created a pathway called the New Technology Ambulatory Payment Classification, or New Technology APC pathway. There's a whole nother analysis related to this. I guess what I would just say about it is that, if you are using any AI tools in the outpatient setting, there may be a new tech APC available for reimbursement there. If you're a developer thinking about applying for a new technology APC, this, similar to the NTAP, has a very sort of specific timeline with meetings with CMS, applications on CMS's system, which is called MIRIS, which, sort of an art form to put in the information appropriately into MIRIS to receive, your application to sort of get through. So this is a whole nother project really to try to put in an application for a new tech APC, but it is a way to start to receive payment maybe in a more expeditious manner in the outpatient setting for your product. And, we do see that once a developer has started to receive payment, maybe in the outpatient setting, that could help them then receive payment in the Medicare physician office setting, or vice versa. So this is one pathway that we see a lot of companies pursuing. And we also have seen for a lot of these diagnostics and imaging related AI models that having payment in the outpatient setting is particularly helpful on the clinical side. So this was another one to look into, the new tech APC. Next slide. So here's my own personal favorite fee schedule, which is the physician office fee schedule, or Medicare physician fee schedule, which, as with the inpatient schedule and the outpatient, this comes out annually from CMS. This is a chart that just shows the methodology. RAND put this out when they were examining AI payment, of how the Medicare physician fee schedule works. So essentially, your payment equals your work relative value unit times plus your practice expense relative value unit, plus your malpractice relative value unit, times your conversion factor. All of that is to say, CMS is paying for AI the same way that they pay for other types of medical services, but it is only within this practice expense, this middle bucket. And within that, it is mostly within this indirect practice expense component. So work RVUs have not been something that we've seen so far in payment for AI services. Malpractice RVUs have not been something that we've seen for AI services. Those have been put up as 0. We've really seen CMS looking at a lot of the AI tools, even, fully diagnostic tools that are being reimbursed, as indirect practice expense. So non-clinical labor, IT, similar to an EHR or some other kind of software system that you're using. We've also seen some work around direct practice expense, which is where many advocates think that all payment for AI for now should belong, which is a per patient encounter clinical service would be more appropriate than some of the indirect practice expense RVU valuation. So we are seeing a number of different AI models be reimbursed. The payment rates are all over the place based on, really what the value of the service is and how much it costs for the innovator to perform the service and how much it costs for the clinician to really provide the service within their office. Some rates are much lower than what we're seeing for the similar physician rate, and others are almost at the same as what it would be for a physician. So it really is service dependent, and each of these are being valued based on that clinical service and within the suite of services that for that type of medical specialty. So this is very dissimilar from remote patient monitoring or remote therapeutic monitoring or even prescription digital therapeutics, which has its own set of issues. We're really seeing each different type of AI service looked at differently, valued differently, coded differently. It is not being paid at a fraction of the MPFS rate of a clinician performed service, like many telehealth services are done. They're receiving their own unique codes and their own unique payment under the MPFS. Next slide. The other thing that we're seeing, which is super interesting, I think, is a real dovetail into value-based care models utilizing AI and AI being incorporated into quality measurement. So for example, for folks who are working at all in the sort of value-based care space, we do have the MIPS, or the Quality Payment Program, that came out of the Medicare Access and CHIP Act in 2015. That created pathways for different types of value-based care models that are intended to lower overall costs and raise quality of care. For example, the Merit-Based Incentive Payment System, or MIPS, if you participate in that, which many clinicians do or are required to, you can receive plus or minus 9% of your Part B revenue. Or the Advanced Alternative Payment Models, or AAPMs, for which you can receive plus or minus 3.5% of your Part B revenue. Clinicians and providers and hospital systems and FQHCs who are participating in these sorts of models, we're starting to see AI codes and services integrated into the measures, such that if you could, if you wanted to try to report on a specific MIPS measure, the use of an AI tool may allow you to do so. And I have an example about that in a second. With respect to HEDIS, that's another huge area. Many of the insurers require, HEDIS reporting. It's a tool used by more than 90% of health plans. And a question we often receive from some of our provider friends is the use of this AI, is that going to help me meet the HEDIS measure? Or, does it meet the HEDIS measure for purposes of reporting for US health plans? That's administered by NCQA. And similarly, we are seeing AI tools be integrated into HEDIS measurements, such that if you're using the AI tool, you can meet the measure just as well as if you had a clinician interaction, or if you had had used some other kind of diagnostic tool. So that has been really great to see as well, and we expect to see a lot more of that. Next slide. So one example of this on the MIPS piece, CPT 92229, which is, we talked, I think, a little bit earlier about IDx-DR, which is now named Luminetics Core, which was the first AI, fully autonomous AI service to receive an FDA authorization and to receive a payment in Medicare. That service images the retina, and it detects whether or not the patient has diabetic retinopathy, and diagnoses it at the point of care in the primary care setting. Typically, that diagnosis would only be able to be done in the specialist setting. So that code has really, that service has really been a leader in this space. And just as recently as November of last year, we did see that for the MIPS clinical quality measure specifications, that they did, mention CPT code 9229 and talk about how it met the measure, the MIPS measure for the diabetes eye exam. And we do expect to see a lot more of these AI tools being actively included in the MIPS measures, the ACO measures, all of the different quality measurement reporting that clinicians typically do to participate in Medicare and with private insurers. Next slide. Here we see the HEDIS measure. So this again is for HEDIS for diabetes eye exam for patients with diabetes 18 to 75. And again, we are seeing the AI tool here. It's automated eye exam 92229 specifically included in the HEDIS measure. So I think what this means is we're seeing a lot of folks who are understanding better that the AI tools, once FDA validated as medical services, can be incorporated into our existing quality measures, value-based care models, and that to the extent that it improves care, meets our workforce concerns, and or fills gaps that we are seeing due to rural healthcare lack of access, that these things should be included in some of the quality measures that we have now. Next slide. Okay, so that was reimbursement. You can be reimbursed on inpatient, outpatient, Medicare physician fee schedule. But what about coverage? It doesn't do me any good to be able to bill for my AI service if the service isn't going to be covered. And this is an issue that, frankly, Congress is still struggling with, and I could see different iterations coming in addition to what's happening with reimbursement on the coverage side as well. This actually comes from CMS, the agency itself, this chart that's here, but this is the TCET pathway or timeline. TCET stands for Transitional Coverage for Emerging Technologies. This is the new Biden administration version of what we previously had, which was the proposed the Medicare coverage for innovative technologies, the Trump program. But both programs are meant to allow for earlier coverage for truly innovative technologies to get them into the hands of clinicians and patients more quickly. The coverage folks and this is a Medicare program, the coverage folks at CMS are overwhelmed and inundated with a lot of new types of healthcare services and testing. And so this was looking at how can we, once something does have an FDA authorization, and particularly if something is FDA deemed a breakthrough medical device, can we try to make sure that there is appropriate coverage when reasonable and necessary for patients. So this talks about some of the pathway. So a product would need to go through FDA and CMS review. And there's also this concept of sort of whether or not something is covered should be looked at the same time that the FDA is reviewing the product. So we don't want to have a product go through 6 years of FDA review and then wait another 4 years to get coverage. Like that's 10 years that no patient is able to use this product. So kind of coordinating and aligning FDA and CMS so that they can be looking at the same thing at the same time, and even sharing learnings is a big concept that I think was really positive in the TCET pathway. The concept would be you would get this coverage for a number of years, but then it would expire. You would transition to a post-TCET coverage or more permanent coverage. There were a couple concerns with this pathway, even though this is what we have on the books right now. One is that CMS said that they would only have about 4 products a year that they might be looking at. That's just not enough. We're seeing hundreds of applications going into FDA on AI tools and models. So this is, that piece I think was panned as woefully inadequate. Although some experts I've talked to have said that actually they think makes sense in their view. And then another issue was, okay, we have this TCET sort of temporary coverage for here they're showing, years 3 to maybe 5 years of coverage. But what happens after that? There's sort of a fall off in terms of permanent coverage. Would it not be better to just come up with a permanent coverage solution, or to give, stakeholders, including the developer, innovator, clinicians and patients, some understanding or assurance that there would in fact be coverage. If you're a physician office, it's really hard to invest in a new AI tool if you're not sure whether, because you're in year 4, your patients are going to be able to use it 2 years from now. So this I think is still something that's being iterated over in Congress. They have a couple bills that relate to this specifically. One passed recently out of Energy and Commerce Committee, but this is on the books what we have right now, which is better than what we had before, which was nothing. This TSET pathway for coverage. Next slide. Just want to quickly hit on this because I think we only have about 5 minutes left. With respect to coding, you need payment coverage coding to be able to bill for an AI service. There is a taxonomy that the AMA put out for AI services in the last couple of years. Again, that's been tweaked over the past couple of years, but they do define different types of AI. It's worth a look. If you're a developer, certainly, but also if you're a clinician, just to kind of understand how these medical services are being looked at in the space of AI. And it's super interesting to me how they're getting their own unique codes. So they do set up these different terminology that we are hopeful will become more ubiquitous across healthcare, how to differentiate against the different level of autonomy within AI services. Next slide. And this gives more kind of, this chart says the same thing, but it gives more examples of assistive, augmentative, and autonomous AI. And there you can see some examples, the coronary fractional flow reserve, or FFR, heart flow type of augmentative AI. The autonomous AI, the one they mentioned there, again, you can see is 92229. And then purely assistive, which is, a lower bar of just information that is helpful to the clinician generally. Next slide. Great. Ended with 3 minutes left. Thank you all so much, and I'll turn it over to Sylvia and Aislinn.
All right, thank you so much, Sybil and David. There was a lot of great information there, and just to echo a lot of the thank yous in the chat, and a lot of people wanting to check out this resource. So we will be sure to make sure this recording and these slides are available within the next few days, probably the end of the day. I'll get it on it as soon as I can. Yeah, really great session. Just as a reminder to our attendees, if this was helpful for you, there is more to come. This is only part 2 of our AI learning series, so please continue to join us. Check out the recording of part 1 on our YouTube. The recording link is in the chat and will be shared. But thank you everyone for joining us. Sybil and David, this was super helpful, super educational. Thank you so much. One last mention, just for those who are in Sacramento or Fresno or the Los Angeles area, if you're California based, we would love to have you at an upcoming event. We are having digital health workshops in 3 areas. We'd love to see you in person and really get hands-on on digital health and learn a lot. So please join us for an upcoming event. Thank you everyone for joining us. I hope you have a great rest of your day, and we'll see you soon. Thanks.